It's I did plan for a full 1 hour, but I think it's a short group, so let's just get started. So I'm Janil, and I'm an assistant professor of Epi here at the School of Public Health, and also affiliated with the Center for Pediatric Population Health. What I have not listed here is also my second affiliation with the Southwest Center for Occupational and Environmental Health, well, where I play a role of the director of the pilot project program and also the occupational EPI doctoral training program. So all my work pretty much focuses around the epidemiology of birth defects, as well as a specific focus on occupational exposures and in particular co-occurrence patterns in this birth defect. So for this presentation, I have gathered information from three of my, I would say, most prioritized projects that I've been working so far. One of them is already published. The first one that I'll be focusing about is already published. The second was published, and the third one, based on that publication and results, we're working on a new project. So this should pretty much flow like a story. So before we talk about any of my projects, just a little bit of a background on what birth defects are. So a birth defect, as a definition, is any structural anomaly that is present at birth, and it can be caused by genetic abnormalities and or environmental exposures. And you'll be surprised to know that 85 to 90% of these birth defects go with an unknown etiology. That means the underlying risk factors are often unknown. So birth defects can be isolated, or it can present in a characteristic combination or pattern that may affect one or more organ systems. So for example, if someone has a heart defect of the cardiovascular system or congenital heart defect, they're definitely more likely to have an underlying birth defect in other organ systems. Let's say for boys, it may be something like a hypospadias. Regardless of gender, it may be something that can be spina bifida or anything related to the CNS. So birth defects are often present in a combination or a pattern. Okay, so talking about the burden and impact in general, birth defects are very common. Not surprisingly, every 4.5 minutes, a baby is born with a birth defect in the United States, and that is kind of alarming. It affects 1 in every 33 babies, so the probability of kid having a birth defect is quite high, I would say, if it's 1 in every 33 babies. So it's 3%. That's the prevalence, and that translates into about 120,000 babies with birth defects every year. Now, each year, the total hospital costs for U.S. children and adults with birth defects, they exceed $23 billion. And this does not include any outpatient care or any other provider charges, okay? So birth defects are critical. Birth defects cause 1 in every 5 deaths during the first year of life, and they're critical conditions that can cause lifelong challenges, okay? So imagine the burden and impact, taking it into account that 1 in every 33 babies is born with a birth defect, and then 1 in every 5 babies with a birth defect results into a death during the first year of life. So this is very alarming, and it's kind of a very frustrating public health problem, as well as a medical problem worldwide, because there is not much that has been done. I mean, there's a lot of genetic studies that have been done. There's a lot of sequencing data that has been extracted. But at the end of the day, how to find out the serious implications that are caused by the birth defects, and how do we prevent those? That's a moral question. And on top of that, the added complexity of 80%, 85% of these birth defects, we still do not know the cause, whether it's genetic, whether it's environmental, or whether it's a cross combination of genetic as well as environmental risk factors. So some more numbers: an estimated 240,000 newborns die worldwide within 28 days of birth every year due to congenital disorders. And 9 out of 10 children born with a serious congenital disorder are in the low and middle income countries. So when we step outside of the United States, this problem complicates further. And you might have seen the studies from the Global Burden of Disease collaborative agency that neonatal and under 5 mortality rates decline. As they decline, the congenital disorders become a larger proportion of the cause of neonatal and under 5 deaths. And the most common severe congenital disorders are heart defects, neural tube defects, and Down syndrome. So Down syndrome, again, it's a chromosomal thing. And then if here in this presentation, we'll be talking about non-chromosomal isolated major birth defects. Okay, so there's quite a complicated classification of birth defects, but in general, it can be major or minor, and it can be chromosomal or non-chromosomal. Now, although congenital disorders may be the result of one or more genetic, infectious, nutritional, or environmental factors, it's really difficult to identify the exact causes. Okay, so with that, I'll talk about my first study, which is on maternal occupational exposure to polycyclic aromatic hydrocarbons, or PAHs, and the risk of CHDs. Now, as complicated as this title looks, it's really not. The exposure here is polycyclic aromatic hydrocarbons, which is called PAHs, and I'll call them PAHs from this point. Excuse me. And the outcome is congenital heart defects. Okay, so we'll talk a little bit about the background. Though congenital heart defects are the most common type of birth defects. Okay, they occur in 1 per every 100 live births, and they are also often known to occur in association with different syndromes. And there are many teratogenic exposures affecting the fetus that have been already shown to be associated with CHDs, such as anticonvulsant use, maternal pregestational diabetes, maternal obesity. But then most of the causes are due to unknown etiology. Okay, most of these cases are where it's really difficult to find the risk factor that is behind it. So the identification is further complicated due to clinical heterogeneity. Now, CHDs are not as simple to classify as any other birth defect. They're the most complicated birth defect to be classified. They occur in, there are different classification systems all across the world. One is called classifying them as simple, isolated, or multiple. Then there are other ways where you can classify them by a specific part of the heart that is involved and things like that. So now, one of the risk factors that have consistently stood out in terms of being a causation or related to the causation or causal pathway to CHDs are the environmental and occupational risk factors, and that's where my expertise really comes into play. And one of the common pollutants that is believed to be associated is the PAHs. Okay, so what are PAHs? What are polycyclic aromatic hydrocarbons? They're a group of chemicals formed due to incomplete burning. Okay, so coal, oil, gas, wood, garbage, and there are more than 100 different types of PAHs in different structures that are present in the environment. Okay, they are often occurring as complex mixtures, and the primary sources for these are tobacco smoke, wood smoke, ambient air, and consumption of charbroiled foods. In regards to occupational exposures, one of the most common PAHs that all of you might have seen is, let's say, going to a pizza place like Blaze Pizza or Hi-Fi, where they cook pizzas right in front of you, right in front of the brick oven. That's like a major source for PAHs. So imagine the complication that may occur if a mother who is pregnant carrying a baby who is about to deliver in, let's say, 5 to 6 months from now, and if she's working there, imagine the amount of PAHs she's inhaling if she's working a day shift, let's say from morning to evening. So that is one of the commonly, at least in the animal models, PAHs has been related to different types of teratogenic effects. It is lipophilic and water soluble, so the mechanism of action is that it gets converted into intermediates that binds with the DNA, and that causes cellular mutations. So in lab animals, a lot of studies have been done on PAHs and reproductive effects, and PAHs have been linked to fetal death, low fetal weight. There has been a little bit of a conclusive evidence, but it's not still substantial on several birth defects. A lot of PAHs and CHD studies have been done in fish and rodents. And the teratogenicity may be based on the genotype of the fetus. Human studies, on the other hand, are relatively having less information just because of the nature of this outcome. Birth defects in general are rare, and it's really difficult to ascertain the risk factors for birth defects in time, in real time, right? And in human studies, although there have been few case control studies that have been done, and there have been associations that have been shown between pHs and intrauterine growth retardation, decreased birth weight, and length. So the previous studies that have been done on pHs and CHDs, there are this couple of studies. I'll not go into too much detail, but both of these studies are pretty much dated. At least the first one is, which is from 97 to 2002, with a limited number of samples, found that there were some non-significant associations with conotruncal defects, septal defects, and it suggested that they implied that future investigations are necessary for high prevalence populations. A recent study in Asia, an Asian population, where this was published in Nature Scientific Reports, the 2018 one, they found significant associations. They found 2.03 odds, so, which means mothers who were exposed to pHs were twice likely to deliver a baby with a congenital heart defect. And then they also looked at different subtypes of this congenital heart defect. One is the septal defect, one is the conotruncal heart defect. In septal defects, they found the odds ratio of 2.37. So again, basic epi, mothers with exposure to pHs were 2.37 times likely to have a baby with a CHD compared to mothers who did not get exposed to pHs. So we are working, even right now, I'm working in this study that is called the National Birth Defects Prevention Study. It's also called the NBDPS. And in NBDPS, the study basically started in 1997. It ended in 2011, but then it started again in the form of another name that's called BD-STEPS, which stands for Birth Defect Study to Evaluate Pregnancy Exposures. So this NBDPS is kind of a treasure chest. It has data on 44,000 women. In these 44,000 women, around 12,000 were cases. So these were women who delivered babies with a birth defect. And then the 32,000 women were controlled. So they were from the same region, women from the same region who delivered healthy babies. And all these women, all these 44,000 women, they were interviewed after the delivery, and they were interviewed back in time. So 3 months before their pregnancy, all the way to the end of their pregnancy. And they were asked about different exposures, like what different exposures they were getting exposed to. So let's say smoking, alcohol consumption, jobs, what jobs did they hold? And so this slide essentially shows like how was the pH's exposure coded in NBDPS. So in NBDPS, for all these women, for all these 44,000 women, the jobs that were held for at least 1 month during B3, which is 3 months before pregnancy, to P9, which means till end of pregnancy, was collected. And then these jobs were externally classified based on the standard occupational classification system. And this was done by expert industrial hygienists at NIOSH, which stands for National Institute of Occupational Safety and Health. And I've worked with a few of these industrial hygienists, and this is the job that they are really invested into. All they do is they get this job information from these mothers, and they externally classify as to how much of an exposure to a certain chemical or a risk factor they get exposed to, okay? And in order to increase the accuracy and reliability, they have a training session that is done before the review. There are several industrial hygienists who do the coding for the same data set. And then independent rating for each job is done, and they examine the rationale and assumptions behind that specific workplace. First, they start with a sample set of 100 jobs, and then they go and move on with the full data set. Okay, so there's independent coding. They're blinded to case control status. They do not know which women have delivered a baby with a birth defect and which women have not. And then there are different ways they have collected this exposure. So here for this study, the exposure was defined as total cumulative PAH exposure in the critical period was more than 0. Okay, so if anything was more than 0 for one or more of the jobs that they held during the critical period, that was considered as an exposure. So in terms of the dichotomous rating, anything more than zero was considered as a one, which was considered as a yes, and anything as a zero was considered as a no. And for the study participants, the cases and controls, right? So the CHD cases and unaffected controlled infants came from the NBDPS with their estimated dates of delivery from October 1, 1997 through December 31st, 2011. These were relatively homogeneous case groups. We all excluded minor CHDs. We also excluded syndromic CHDs. So these are all plain, simple, isolated CHDs. We also had information on pregestational diabetes, multiple gestations, and family history of heart defects. And we also had information, and these were analyzed when 100 cases were available for the subgroup. So if for any subgroup of CHD, if there were less than 100 cases, they would be excluded from the analysis to hold the study power. And this is a quick review of the analysis that we did. So there was frequency distributions of the 23 major job groups. The thing I was talking about, the standard occupational classification by exposure status. So for each of these specific job groups, let's say if it's maintenance industry, or if it's engineering, or if it's healthcare. So for each of these major job groups, we had frequency distributions of exposure status, how many of them were exposed to pHs, how many of them were not exposed. And I won't go into too much of this detail, but this is the formula that was used, that we used, and so that accounted for the weighted intensity in milligram per hour for the pHs. Then we also accounted for exposure frequency in hours per week. So based on the job, that would be 40-hour week. We also calculated, we also accounted for the number of days that would be worked in the critical time period. And then the sum of these job-specific cumulative exposures was considered as the final exposure. In terms of analysis, we did a below, at, or above median analysis, which was an exploratory analysis. And then we also did the quartile analysis to assess the cumulative exposure of pHs in terms of quartiles. So if they're exposed into the lowest quartile, what was the risk of CHDs? If they're exposed into the highest quartile, what was the risk for CHDs, and things like that. We also accounted for several confounders, and you all know what confounding is by this stage. If not, confounding is a presence of an external variable other than the exposure and outcome, which creates a spurious association or false association because of its presence. So, for example, in the easiest way, we all know that smoking causes lung cancer, right? So now, if we do not check for alcohol consumption among smokers, now smokers by default tend to have a higher alcohol consumption. So alcohol is a confounder here. So that's a simple way of telling everyone what confounding is. And so we checked for confounders in the final models. We made sure to account for BMI, gestational diabetes, number of previous births, alcohol use, secondhand smoke at work, meat consumption, and anticonvulsant use, because one or two of these, or pretty much all of these, are related to CHDs, and there's also some way of their association with the exposures as well. The final models were adjusted for, after checking for confounding, they were adjusted for maternal age, race or ethnicity, education, smoking, folic acid supplementation, and study center. Okay, so with that, we also used something novel for this study in order to assess confounding. So let me ask you all a question. How many of you know what directed acyclic graphs are, or DAGs? Have any of you heard about those? Okay, I pretty much know from all of you that I see here on screen. So so DAGs are, and I teach DAGs in my Epi 3 class. They are one of the most fascinating things that I've seen in Epi, okay? So these are visual representation of causal assumptions by making underlying relations explicit, okay? So let's say you're dealing with a data set that has hundreds of variables. Let's say you want to know the exposure, you want to know the relationship between maternal smoking and low birth weight, okay? So let's say hypothetically you get this data set from Texas Department of State Health Services. You get that data set, and now you have hundreds and hundreds of variables, and then you will be confused, like, oh no, how do I account for all these other variables? All I need to know is relationship between maternal smoking and that low birth weight. And then you also see, okay, there's also some information on maternal medication use. There's also some information on infections that mother had during the pregnancy. Okay, so now you have this 25 different variables that you know that you don't want to measure, but you still want to see what's their effect on your main association between smoking and low birth weight, right? So when you have lots and lots of variables, when you have a complicated data set, or when you really want to look for confounding, if that is created or if there's a false association that is created by external variable, that's where the directed acyclic graphs come into play, okay? So the reason it's called directed is because all the variables in the graph are connected by arrows. And the reason it's called acyclic is if you follow the path from one variable, the direction of the arrows will never bring you back to that specific variable. And that's the reason they are called directed acyclic graphs. Now, I won't go into too much technical terms here on this slide, but let me give you an example. So this is a directed acyclic graph, okay? Now, in this, you first have an exposure. So here in this study, we had the exposure, which is pH's exposure at workplace in pregnancy, and our main outcome, which is congenital heart defects, okay? And that's why this question mark shows that this relationship is the key or the fundamental relationship in the directed acyclic graph that we are trying to assess, okay? Now we list down all these variables. Forget all these arrows and the lines right now. Just focus on the arrows, right? So we have maternal race, we have education of the mother, we have meat consumption information. We know that meat consumption is where charbroiled. Oh, you cannot see the PowerPoint. Oh, how did that happen? Hold on. Thanks for letting me know. Sorry, I didn't know this was not able to see it. How about now?
We can see it now.
Okay, perfect. So this is a directed acyclic graph, okay? So this is pH's exposure at workplace in the pregnancy, which is our main exposure. And we have congenital heart defects, which is our main outcome. So this is the fundamental relationship that we are trying to assess, okay? And so this question mark shows that pH's exposure and CHDs is the main association in question. And so you can also see, so for now, just look at all these other variables here. Forget the directions of these arrows, forget about the lines and arrows. Just look at all these variables. So you put down all these variables on the graph. We have maternal race, we have maternal education, we have meat consumption because meat consumption, charbroiled meat is associated with pH's exposure. Remember, we have smoking, we have secondhand smoke at work, we have age at delivery and things like that, okay? So now each of this arrow represents a causal pathway, okay? So let's say for race and education, we look at the direction of this arrow, it means race is associated with education, okay? And then education is associated with pH's exposure at workplace in pregnancy, okay? And not the other way around. When the arrow goes from race to meat consumption, we can say that having a particular race is going to put you more likely to eat meat or not, but not the other way around. If you're eating meat, that does not mean that you are belonging to a certain race. So these all arrows, so let's say here, certain race, we also know that in certain race groups or race ethnicity groups, there's a higher prevalence of smoking. So race is related to smoking. And then when you are smoking, you are also more prone to have secondhand smoke at work because you would have colleagues. And when you have secondhand smoke at work, that is actually releasing pHs, and that's where you have pH's exposure at the workplace. So this is how you connect all these arrows. And then you have to see a backdoor pathway. What we call as a backdoor pathway is when you have a variable that has an arrow that is going towards the exposure. So for race, it goes to education and then to the exposure. And it also, there's an arrow that goes to the outcome. The race is also associated with CHDs. People of certain, say, not, for example, non-Hispanic whites have a greater risk of congenital heart defects compared to non-Hispanic blacks. So you rely on this previous literature, previous science, and previous biological plausibility to draft out all these arrows. And then at the end of the day, you try to find out the backdoor path. Whatever variables that have a backdoor pathway that is associated with the exposure and outcome, and it's not in the causal pathway between the exposure and outcome, is identified as a confounder. So here in this specific example, if we control for race, then all the effects of these other variables, anticonvulsant use, infant sex, age at delivery, meat consumption, will be essentially diminished, and we will be able to assess the purest association between PH's exposure and congenital heart defects. I really love DAGs. There's a 3-hour class that I usually do during my Epi 3 class, and it's one of the most popular topics in my Epi 3 class, and I use this example a lot. So I know we are very short on time today, so I'm not going into too much detail, but to assess confounding or to assess the presence of an effect from external covariates on your main association that you're trying to study, the DAGs are really a great thing to learn. And you can Google up DAGs. There's also this website called Daggity, and if you go to daggity.net, you can actually draft DAGs, and that can also generate a code for you that can help you in analyzing the data on R or SAS. And based on that code, you will be able to identify how much of the presence of confounding is in effect due to all those other variables that are present in your data. Okay, so now I won't get too much technical, but please feel free to reach out to me if you have any questions about the DAGs. But in terms of the study results, we started with 12,584 cases and 11,829 controls. And then obviously, because of the selection criteria, we only selected cases and controls who were employed for at least 1 month during P1 to P3, which is 1 month before pregnancy to end of first trimester, because that is considered like a critical window for the exposures to CHDs. And so then, and we had 8,644 cases and 8,140 controls. And then we excluded all of these. We excluded the ones that had pre-gestational diabetes because it's a well-known risk factor and a confounder. We excluded multiple gestations. We also excluded first-degree family history of CHDs. We excluded extracardiac cases, association cases, and complex cases. So now we only have a very pure group of primary isolated cases. Remember selection bias and information bias. You want your population to be similar in terms of characteristics in order to learn any risk factor that is present in them. And so we ended up with 4,775 cases and 7,734 controls. In the descriptive analysis, we found significant differences in infant sex. Among cases, there were 45% females. Among controls, there were 49% females. In terms of education, education was higher in control mothers. So mothers who delivered healthy babies had a greater education level compared to mothers who delivered babies with CHDs. BMI was higher in mothers who delivered babies with CHDs compared to those who delivered healthy babies. We found overall prevalence of exposure of PHs to be similar, which is good. You know, you want similar exposure in both your cases and controls. If you have similar exposure level, you will be able to assess how many, in spite of having a similar exposure level in both cases and controls, these many women ended up having a baby with a CHD. Okay. The most frequent jobs that we found were related to food preparation and serving related jobs, and also sales and related occupations. Okay, so this was above and below median analysis based on the amount of pH exposure, which ranged from, I think, 0 to 290 microgram per cubic meter an hour, which is essentially the scale for measuring PAHs. we found here you can see different types of CHDs. One are the conotruncal heart defect. This is the tetralogy of Fallot. This is detransposition of greater arteries. And for each of these CHDs, you can see the crude odds ratios 1.15, 1.43, and 0.66. You can see here for those, and these first four columns are for those who were exposed to low levels of pHs, which is below median. And the last four columns are the ones who are exposed to high levels of pHs, which is above median. Okay. So among those who were exposed to higher levels of pHs, so if you look at the last four columns, the probability or the odds of having tetralogy of Fallot, which is one type of a CHD, was significantly higher. You can see these are significant, and that's why they are marked red. And so you can see that mothers who were exposed to at or above median levels of pHs were 1.43 times more likely, or 43% times had more higher odds of delivering a baby with tetralogy of Fallot. And then we just did not do above and below median because we thought, let's break these levels of pHs more. So then we broke them down into 4 different quartiles of equal levels, equal percentiles each. And that resulted in quartile 1, which was ranging from 0.04 to 7.53, all the way to quartile 4, which was over 219.43. So this was where women were exposed to a really, really high level of PAHs compared to women in the other, exposed in the other 3 quartiles. And you can see here that conotruncal heart defects, which are one specific group of heart defects, and tetralogy of Fallot, which is a subtype of conotruncal heart defects, but a standalone congenital heart defect by itself. And if not for the first 3 quartiles or first 3 levels of PHs exposures, the women who were exposed to the highest level of PHs exposure had significantly higher odds of having a baby that either had a conotruncal heart defect or a tetralogy of Fallot. Okay, so it's 1.43 and 1.81, which are the odds ratios that you can find here, which are significantly higher. And this was not found in the previous study, probably because the sample size was small and they did not have enough samples to break this down into quartiles. So they just did everything in general, like all cumulative yes or no, and then they were not able to find it here. But now we had like a large, robust data set of 6,944 controls, 790 of them who were exposed. And you can see 1.43 and 1.81. 1.81 is high. That's close to 2. We can say like women who were exposed to higher levels of pHs had 2 times higher odds. They were twice likely to deliver a baby with a congenital heart defect compared to women who were not. And so then we also explored associations between PH's exposure and all these other CHD subgroups, the right ventricular obstructive tract defects, left ventricular obstructive tract defects, septal defects. But the only positive association we saw was in this conotruncal heart defects and tetralogy of Fallot. These 2 specific CHDs were related to higher levels of exposure of PHs. Okay, and then we also compared these odds ratios from previous study to current studies, and you can see here, so many of them have gone down, many of them have gone up, but in general, you can see these are in the ranges of 1.00, 1.10, and this is not based on quartiles. These are generic odds ratios, so you won't see associations here. And that's why we can say that since the previous study was not able to do it by quartiles, they were not able to find that specific type of an associations that we found. So in terms of study conclusion, we found that higher exposure to PHs in the workplace are associated with conotruncal heart defects and its subtypes, tetralogy of Fallot in particular, and future studies with higher prevalence of PHs and inclusion of genetic information among mothers and fetuses may provide further insight in the association of PHs and CHD. And we found different patterns in period-wise breakdowns, as I showed them here. Some of them increased, the risk of some CHDs increased, the risk of some CHDs decreased. So there is definitely some insights that we got from this study that's something going on between PHs and CHDs. So with that, that's the conclusion of my study on PHs and CHDs. And I'll take some time to talk about the other two studies that I have worked on slash I'm working on. Okay. So that was the occupational exposure studies. And remember the other thing I told you about my research expertise is looking at co-occurrence studies. And this is not just me, but it's a group of faculty here at our school who are involved in this. Melissa Richard was the co-first author along with me on this completed study on hypospadias and CHDs. But we also have Dr. AJ Agopian, Dr. Laura Mitchell, and then Melissa Richard herself was a graduate from our school as well. So there's this closed group of researchers from University of Texas, University of Arkansas, Baylor College of Medicine that are heavily involved in this co-occurrence studies. And I find myself privileged to have been involved in two of these major studies. So remember I was telling you in the very beginning of the lecture that birth defects tend to occur in combination, right? So hypospadias is a birth defect that occurs in boys. It's a defect where the urethral opening forms on the underside of the penis rather than the tip. And so there can be two types of hypospadias. One is isolated, one is non-isolated. And then there are different ways or combinations of syndromes, non-syndromic risk factors for both of these. Here is the rationale for the study. So Catherine Ludorf, she's a doctoral student at our school. She published this paper in conjunction with Dr. AJ Agopian, where they found, here you can see the Venn diagram, where you can see there are big overlaps of two different birth defects. So they found co-occurring birth defects among infants with hypospadias. They just picked up kids who were born with hypospadias, and they looked into, like, let's say if this kid is born with hypospadias, how many of these kids also have another underlying birth defect? And so you can see here that there are different birth defects that were present. These are by default, these 2,084 boys were born with hypospadias. And out of this 2,084, you can see majority, like not majority, but 18% of them had an ostium secundum type ASD, which is a congenital heart defect. Many of them had a ventricular septal defect, which is a heart defect. Many of them had a co-occurring urogenital birth defect, which is an obstructive defect of renal pelvis, specified anomalies of bladder and urethra, polydactyly, and things like that. So this kind of made us think, and this is where we thought these three are the cardiovascular system anomalies, and you can see here that they have the highest proportion of birth defects among those who are born with hypospadias. So this made us think, why don't we extract all the birth data from the states of Texas, Arkansas, and as much data as we can get, and see like what is the real prevalence of a baby, let's say, who is born with hypospadias, how likely, or what is the odds, or what is the prevalence ratio of that baby to have a congenital heart defect, right? And the reason also, there are some shared etiology studies, there are several animal studies in which they have found out there are certain polygenic syndromes or certain single gene defects that are common in both CHDs and hypospadias. And then there are also some shared risk factors that have been shown to be associated with two of these birth defects. So there have been really a lot of case studies that have been published by physicians and clinicians that have shown that, okay, we had this case of a hypospadias, and 1 year later, when they were born, they were diagnosed with an undiagnosed congenital heart defect in the previous times. And so these case studies and case series, while they are really helpful and based in terms of evidence, what we really don't get is the population perspective, right? So our objective was to determine whether boys who have hypospadias are more likely to have broad or specific congenital heart defects than boys who were born without hypospadias, and estimate the prevalence ratios for each of the CHDs. Okay, so we had three primary data sources for this study. One is the National Birth Defects Prevention Network, which is the network of state and population birth defect surveillance programs. It has what you see here is all the states that are participating in NBDPN, which is Arizona, Georgia, Florida, Illinois, Massachusetts, North Carolina, um, Nebraska, New Jersey, New York, and Texas. And all these um, states, the numbers that you are seeing here is they are the number of live births in that specific state. So we had data from 422,000 kids who were born regardless of their birth defect status from Arizona and things like that. They report up to 47 major birth defect categories, and we have seen variability between state surveillance programs. And the good part about this is there's a standardized 6-digit British Pediatric Association code classification from 1999 all the way to 2007. And because of the standardization of this core of this code, it's very easy to identify the cases from this data set. Another data source was the Texas Birth Defects Registry itself. We know Texas is big, right? So we have Texas Birth Defects Registry as a separate data source of its own. The registry contains data on active birth defect surveillance among live births, stillbirths, terminations, and fetal deaths. And they have information on at least one monitored birth defect by 1 year of age is considered as a case. Again, they have BPA codes, and the data goes all the way from 99 to 2014. And the third data source is Arkansas. The reason we have Arkansas here is because I had done my birth defects research fellowship after my PhD in Arkansas, and I continued to collaborate with that specific monitoring system. So I try to capitalize as much as I can get from my previous set of collaborations. And so I was able to get information from Arkansas Reproductive Health Monitoring System, as well as Arkansas Department of Health, where we got information on 6-digit PPA codes. And they also have information through medical record abstraction and interviews. So the live births data for Arkansas was from 95 to 2013. I won't go into too much detail here, but these are the BPA codes that are associated with different types of hypospadias. So to extract, we would have to filter out these codes, all these listed codes, to identify the cases of hypospadias. And CHDs, on the other hand, congenital heart defects, you can see there's so many different types. And you can see on these 3 slides, I won't go into them in too much detail because they're so complicated in terms of classification, but all these are CHDs. And in the last column, you can see are the minor CHDs that we excluded in order to keep our data set robust and uniform. In terms of analysis, we did Poisson regression, which is a regression done for counts data, where exposure was kid having hypospadias and the outcome was kid having a CHD. We adjusted for the following confounders like maternal race ethnicity, the year of birth, and also the state of the birth. And then we also have secondary covariates, which are maternal diabetes, hypertension, and smoking, which are based on the variables that are related to either the exposure or the outcome based on the literature review. And so here are the results. And the results were alarming and very, very striking. So the first column here you see, the first table, the first box here you see is on NVDPN, which is a collection of 10 states. The second itself is Texas, and the third itself is Arkansas. Okay, and you can see here PR, the third column here, the third column in each box are the prevalence ratios. Okay, and this prevalence ratios, if you can see, for all CHDs combined, so kids who were born with hypospadias were 16 times more likely to have a CHD compared to kids who were born without hypospadias. This prevalence ratio was high in Texas as well, 5.8. Kids who were born with hypospadias in Texas were 5.8 times highly likely to have a CHD compared to kids who were born without hypospadias. And you can see this prevalence ratios if we delve into each and every specific phenotype or subtype of CHD, let's say common truncus arteriosus, TGAs, tetralogy of Fallot, single ventricle, ventricular septal defect. For each of them, we found higher prevalence ratios, 9.4, 6.1, 9.5. So this was a big eye-opener a study strong enough to get it published in JAMA. And you can see we also found these are the other congenital anomalies for heart, and consistently these were higher from 4 to 6, 6 to 8, somewhere even at 8 to 9. And so you can see that CHDs are more likely to occur in kids who have hypospadias. These are other CHDs, PDAs, coarctation of the aorta, the other anomalies of the aorta, and you can see the prevalence ratios are consistently significant with a tight confidence interval all throughout. And so this was some groundbreaking results that we found. The study has already been published, and the initial analysis suggests that CHDs are 5 times more prevalent among boys with hypospadias than boys without hypospadias. The data from Arkansas was similar to estimates from Texas. We also need and we also encourage further work from other states, which is needed. Although we had like a combined information from 10 other states, we still require more work to evaluate the accuracy of these associations. And so this also brings into question, like what other birth defects have a higher risk of co-occurring CHDs? And so I took on this task of doing cleft lip and cleft palate. All these kids who are born with cleft lip, with or without cleft palate, how much risk do they have for CHDs? Okay. We did some sensitivity analysis and some maternal health adjustments, stratified analysis. Regardless, they're coming out to be robust PRs. These prevalence ratios are not changing. They're still showing up the same strong association as they were showing up without any adjustments. So on our third study that we are doing right now, which is on clefts and CHDs, and this one is undergoing right now, you'll be surprised to know that the genetic etiology is very, very similar, even more stronger between clefts and congenital heart defects. And you can see here some news briefings that I have brought, like scientists have found genetic mutations, the common genetic mutation that causes cleft lip or cleft palate and heart defects. And so we did another analysis between Texas and Arkansas, looking at the risk of CHDs among kids who were born with cleft lip or cleft palate. And you will be surprised to know that we found, again, a higher spectrum of prevalence ratios. 9.9 kids who were born with cleft lip or cleft palate had almost 9.9 times more odds or more prevalent. They were 9.9 times more prevalent to report a congenital heart defect. And in Arkansas, it was 13 times. So you can see this odds ratios were consistently higher again. And so we're like, okay, if we keep doing this epidemiological work and if we keep finding this consistent odds ratios, what do we do next? We need to find out, right? What are the genetic mutations? What are the common SNPs between CHDs and these other birth defects? And so our initial analysis, while it has suggested that their CHDs are 10 to 14 times more prevalent among kids born with cleft lip with or without cleft palate, we are now working on writing an R01 grant, which goes to the National Institutes of Health for a review that not only checks into epidemiology, not only delves into looking at the numbers, but we also are working with geneticists and clinicians from Baylor College of Medicine and our school who will be actually taking buccal samples from mothers, fathers, and babies who are born with these birth defects. And we will be analyzing this. We'll be doing some genotyping with the help of geneticists, and we will be getting the GWAS panels and also candidate genes to see what are the common SNPs or common pathways between these kids who were born with cleft lip with or without cleft palate and CHDs. And so for that, obviously, we need money. And so we're writing this grant, which goes as an R01 grant, probably by the end of this year. So with that, we are at 10:52. So I will conclude my slides here and my presentation here. And I'm open to all the questions. What do you all think? Share some insights. What do you all think about the things that you learned from the presentation? If not questions, does that strike a question to you all, or does that strike a question in terms of how big of a public health problem this is?
I thought it was interesting because I've done research with FASD. So it was interesting to kind of see kind of links, especially because my lab is now trying to find the actual genetic mechanism back at A&M of why FASD is occurring, how specifically does alcohol affect genetically. So I think it's interesting just to see kind of that parallels in other birth defects as well.
That's awesome. Yeah, I know you have done some work, Namisha, because you've been our summer scholar with us in the past, and I've heard your presentations and things like that. But what is the data set that you are all using? Like, are you collecting data hands-on, or
Yeah, at
and
A&M,
how difficult it is?
yeah, at A&M it's a actual like wet lab, so we actually have the mice. We're raising them, dosing them, sacrificing them, and doing the data from there. So my research over there has been using actual like mice fetuses that we're getting to actually calculate the birth defects on the face. So yeah, we've actually figured out that yes, paternal alcohol does affect. So now it's really trying to figure out how exactly what is in the histones that is being unwinded and what is actually causing the eyes to move apart, the nose and lips to be moving apart, or so on and so forth.
Great. Yeah, I wish you good luck with the studies, and I'm hoping to find more. Anyone else? Viviana, Eben, Alejandro.
I just think the program that you were mentioning, the DAX program is very interesting, just how it can make all those different connections from the different variables. Yeah, I would definitely love to learn more about that and how that can be utilized for data sets.
Absolutely. So DAGs are I love DAGs. I always get excited about DAGs when I'm in the confounding of identifying the confounding phase. And I think there's this really nice article. Let me share it to you here in the chat box, so you can always go back on Teams and retain that. But there's this one study that I always share with my class, and it's such a nicely written study by Tennant. Um, Tennant, or no, it's not this one. Oh, PKU. Okay, here it is. Um, it was published in Nature, and so I'll just copy it here in the chat box. Um, but it's an interesting read, and it will give you more information about DAGs. So look into it. Look into the examples they've provided in the article. You'll find it really interesting.
Thank you.
All right. Well, if you don't have any questions, I'll ask you a question to answer me in one sentence, all of you. Like, what is if you were to do a research on birth defects, and if you had studied only this, what I had shown you, the co-occurrence patterns and occupational exposures, what is the next step you would think of? What would you do in terms of improving public health, or what do you think should be done next? As a public health professional, what do you think would be the appropriate next steps given the findings that I presented? In one sentence. I don't want a long answer.
Um, Not sure. I would say maybe like increased awareness for the vulnerable groups.
Absolutely.
I'd say a health education program in the occupational space.
Absolutely.
Um,
Viviana?
yeah, I was trying to fit everything into a sentence. Just um, Something that caught my attention from what you presented was the differences at the end between Texas and Arkansas. So look into environmental factors additionally, and the differences.
Great.
Yeah, I agree about the environmental factor stuff. I think like even like especially since Texas is so big, maybe further dividing it into like urban, suburban, rural areas. See if there's different factors in different areas of the country, like Southwest Texas, where it's really windy and stuff, or different like industrial areas and stuff like that. And then also, yeah, like general education is always a good thing when it comes to getting the public in the know about these important things.
That is all spot on, because that's what we have proposed in our RO1. Because even in Arkansas, there's so much diversity. Arkansas is a very highly rural state, right? So, and all these um, specific communities that are not present across the U.S. are present in Arkansas, like the Marshallese. There are a lot of Native Americans in Arkansas, and they're all saturated in one specific area of Arkansas, and those areas are highly vulnerable, and some of them are even like close to Appalachian regions, where they're highly deprived of basic necessities and education that is needed during pregnancy and things like that. So that is also one component. But excellent point, all four of you. I think this was really impressive to learn that one of you is thinking about exposures, one of you is thinking about health education standpoint, one of you is thinking about policy implications. And this is what public health is, right? You have to make all these ends meet in order to effectively solve a health problem. So I'll give you all back a minute, which probably I'm not, because it's already going to be 11. But thank you for being here and for listening to me. I hope this presentation was insightful for you all, and I hope this helps you. And if you have any questions, if you want to touch base with me, get in research opportunities, feel free to reach out to me. Okay, I'm on the UT directory. Yeah, and thanks Jackson for coordinating everything.
No problem. Thank you, Dr. Patel.
Thank you. See you all. Have a great Friday and a good weekend.
Thank you so much, Dr.
Bye.
Patel.
Bye. Thanks.